That's a good. Okay. Go on.
And
Hmm.
in that hospital, the doctors told patient developed heart attack, and need of ICU was explained there, sir. Subsequently, worsening of breathlessness and chest pain, patient referred here, sir.
Okay. What would you have done if you Ramesh,
Yes,
go
sir.
back to the previous slide. Suppose
Yes,
you are
sir.
in that Nellore small hospital.
Yes, sir.
This lady has come with 1 hour chest pain.
I will do thrombolysis, sir. Based on.
No, you are in that small hospital in Nellore,
Yes, sir.
and this lady came with not 1 hour, maybe 45 minutes chest pain, because she must have come sometime in that 1 hour. Okay, so obviously they didn't have thrombolysis. Don't say thrombolysis, because they didn't have thrombolysis. No, they didn't give. What would you have done?
First, loading dose should be given, sir.
Okay, loading dose means, hey, don't say loading dose. No, say loading dose of what? It can be loading dose of heparin, it can be loading dose of aspirin, it can be loading dose of clopidogrel. So many things are there.
Aspirin
Don't
of
say
300
loading.
milligrams, clopidogrel.
Huh?
Yes, sir.
Huh.
Aspirin of 300
So,
milligrams, clopidogrel of 300 milligrams, atorvastatin of 80 milligrams.
okay. So you must say that. Or loading cocktail for acute MI or something like that. You should say like that. Okay. So that you have done. Then what?
I will explain the need for thrombolysis, sir.
Mm-hmm.
And need for ICU care.
Won't you look at the ECG first?
Yes, sir.
Only if it is ST elevation MI, then you need to worry about all this, no? Suppose there is no ST elevation MI, she just had chest pain and she has got ST depression, and then you still want to give loading dose and give explain that he will need thrombolysis and all.
No, sir. Only for elevation MI, sir.
That you never told me. The first step is first decide what is the cause of the chest pain. Obviously, you're considering it as a case of acute coronary syndrome. But
Yes,
acute
sir.
coronary syndrome can be angina, it can be unstable angina, it can be non-STMI, it can be STMI,
Yes, sir.
ST elevation MI. So, for everything you did not talk about thrombolysis, no?
Yes, sir.
Then, okay. So, did you ask them what is the doctors? Doctors say he had a heart attack.
Yes, sir.
Okay. So then why did they keep it for 1 week?
That is a small hospital that's not having angio facilities there.
Yeah, that's what I asked you. What would you do if you are in that hospital? You are in that hospital, patient came at 45 minutes chest pain, and you do not have any thrombolysis, and you are diagnosed MI. What will you do?
Sir, I will refer to tertiary care, sir, immediately after
When?
giving loading dose.
So, Nellore is not far off. I'm sure there are hospitals in Nellore who do angiogram and angioplasty. Are there? Do you know?
Yes, sir.
Anybody from Nellore here? Anybody know about Nellore? Is there a hospital there doing angioplasty?
I think there is an Apollo hospital, sir, somewhere nearby.
Okay. So
Not sure.
I think Ramesh, your answer is not no. You just because you don't have facility, you don't keep the patient. Say sorry, we have no facility, but we'll keep you. Patient should have been referred immediately. Just stabilize, relieve the chest pain with morphine and oxygen, and give the loading dose of antiplatelet and statins, and You shift to a hospital which can manage MI, because 1 hour is still no. If you can shift a patient within the next 2 hours, also she can still have a thrombolysis. She can still have PCI.
Yes, sir.
So that should be your answer, no? Keeping a patient for 1 week without treating myocardial infarction treatment is not oxygen and aspirin, no?
Yes, sir.
Okay, go on then. So what happened next? She became breathless. From what day
sir,
she became
breathlessness.
Breathless for
Breathlessness
the
on
past,
third day, sir.
from the third day she
Or
developed breathlessness.
past 5 days.
Okay.
And history of palpation for past 3 days, which was regular, intermittent, which lasted for 15 minutes and subsided spontaneously, sir. History of swelling of legs for the past 3 days, which was gradual onset, progressive, not associated with reduced urine output. No history of giddiness, no history of pre-syncope and syncope, no history of abdominal distension, no history of fever, cough, blood in sputum, sir.
So this is also a matter which can be criticized, no? She became breathless on the third day, but they shifted only on 7th day. Well, I don't know whether the patient's problem or the hospital problem, or doctor's problem, who they didn't advise or they advised the patient didn't take it or something. We don't know. But whatever it is, there has been delay. For for the MI treatment also there has been delay, and after the onset of breathlessness also there has been delay for another 5 days. Am I right?
Yes, sir.
Okay.
Coming to past history, no history suggests of rheumatic heart disease in childhood, like fever with joint pain, skin rashes, nodules, and involuntary
That's
movements.
okay. Just
No
say
history.
rheumatic heart disease. Don't say rheumatic heart disease. What is
Okay, sir.
what do joint pain, skin rashes and all do? So they mean rheumatic heart disease?
No, sir. Chest
Or they
pain,
mean rheumatic fever?
fever, sir.
There is a difference between rheumatic fever and rheumatic heart disease.
Yes, sir.
Okay.
No history of
Go on.
rheumatic fever prophylaxis in childhood. No history suggestive of infiltrative heart disease. No history suggestive of congenital heart disease in childhood. Family history: she married at the age of 20 years. It's a non-consanguineous marriage. She had 2 children, one male and one female child. She had 2 elder brothers and 1 younger sister. No history of heart disease in family or sudden cardiac death in family. Personal history: she was taking mixed diet, attained menopause at the age of 40 years. No addictive habits. Bowel and bladder habits are normal. Treatment history: she was known hypertensive for the past 10 years on regular medicine and known diabetic for the past 10 years on oral hypoglycemic agents. No history of chronic kidney disease or major surgeries in past. Summary, sir.
What is missing in your history? You have not told us what drug she is on now when she was shifted. When she was transferred from that hospital to another hospital, what medication was she on?
So she didn't bring any records from that hospital, sir. The attenders, her husband, he is also not knowing the tablets, sir. But I asked the patient only on the drugs only, sir. She's not on insulin, sir. He doesn't know the name of the tablets, sir.
I'm talking of cardiac medications. Not diabetes. Well, diabetes also you should know. What about cardiac medication? What is she on?
The records are not available, sir. While bringing from the
was admitted
hospital,
in
the
your
records are not active.
You admitted in your hospital?
Yes, sir. We admitted. Patient was in ICU.
Okay, and you were involved in her care?
Yes, sir.
Okay. What would you do if the patient didn't bring records? What will you do?
I will restart the medicines, antiplatelet drugs.
But you don't even know what medicine she is on. How do you restart is only if you know the medication, no? Why she didn't bring papers?
Oh.
Because it was left against medical advice, is it?
Yes, sir. Yes, sir.
Anybody else can give me a better answer? You are in a tertiary care hospital. You are in a tertiary care hospital. The patient has come from a Nellore hospital without any papers. Is it important to know what medication she is on or no? Is it important first? That first you tell me that.
Yes, sir.
It is important. Then what will you
It's
do?
important.
I will try to find out the hospital and try to call and ask, sir. Was there
That
any
is the
medication?
simplest thing. You are in Chennai, you can't call Nellore hospital and talk to the doctor, talk to the ICU people and find out what medication they were giving. See, this requires some interest and some extra effort. So it's very easy to say patient didn't bring records, patient didn't bring, doesn't know the medication. But that means you have not made any attempt to find out what medicine she was taking. Okay, go on.
The summarizing is T cell. 56-year-old female, known hypertensive and diabetic, presented with acute onset chest pain, treated outside as coronary artery disease, acute coronary syndrome with worsening of dyspnea with features of left heart failure symptoms. Possibilities.
Well,
First possibility is coronary artery disease, acute coronary syndrome with acute left ventricular failure, sir. The second patient presented with typical chest pain, sir, typical anginal chest pain with breathlessness. So I am thinking of acute coronary syndrome first, sir. With orthopnea and proximal nocturnal with orthopnea, so I am thinking of acute left ventricular failure, sir. The second possibility is acute aortic dissection, sir.
why?
In case of acute, because of acute onset of chest pain, I'm thinking of aortic dissection also.
Was the pain suggestive of dissection?
No, sir. Patient having typical angular type of pain, sir. In case of aortic
What is
dissection,
it?
there will be a tearing,
What
retrosternal
is it?
stabbing,
Yes.
retrosternal stabbing or tearing type of chest pain, which radiates especially to backs will be there, sir.
Okay.
Pain will
So
radiate to back, arms and shoulders
Yes.
and back, sir.
Okay. Then
In acute pulmonary embolism, sir. That
no. Dissection you have not finished. Are you seriously entertaining acute aortic dissection in this patient? That's what I want to know. Anything is possible, but what is in favor of dissection is chest pain, but against dissection is what are the points?
Type of the
Chest pain,
patient had
chest pain
pain,
is not
sir,
like a dissection pain. What else?
By this 1 week, a patient would have compromised by now, sir.
What compromise?
Hemodynamic compromise will be there, sir, because the pain onset is 8 days back.
Yeah, what hemodynamic compromise is there? No, she is in class 4 heart failure. What more do you want? Hemodynamic compromise. That is not compromise. What is the mortality in dissection? Untreated dissection. The first week.
80%, sir. More than 50%.
1% per hour, sir. 30% at first week, sir.
So, what 30% what?
30% at first week and 80% at second week, sir.
Okay. So, the mortality of untreated dissection is quite high. So, there's a considerable chance she could have died. But she has survived. Secondly, the pain of dissection will not go away unless you give analgesic. It's a excruciating pain which doesn't settle down like myocardial infarction because the aortic tear is probably extending unless you bring down the blood pressure or unless it ruptures because the dissection is exposed to the aortic pressure. So the pain will be much more prolonged, much more severe, and very often the patient may succumb. Patient has survived without any treatment for 7-10 days, then the chances of dissection become less and less. You put more money on other conditions. Okay?
Yes, sir.
Okay. Next,
Yes,
acute
sir.
pulmonary embolism. Acute pulmonary embolism. What is the likelihood? What is in favor of pulmonary embolism?
Then pulmonary embolism, there will be excisional dyspnea and excisional syncope will be there, sir. Patient not having any syncope, sir, and patient may have pleuritic type of chest pain, sir. So if the embolism is located in distal pulmonary artery system, patient will have severe pleuritic chest pain.
So this history is not suggestive of
Onset-
acute pulmonary embolism.
Sudden
The
onset,
most common,
acute onset
the
of
most,
breathlessness.
the most common symptom of pulmonary embolism is either fainting or, more important, is dyspnea.
Dyspnea, sir. Excisional dyspnea, sir.
Chest pain can occur, but chest pain is not the primary symptom. Okay. What about acute pericarditis?
In case of acute pericarditis, patient having will have severe pleuritic chest pain, sir, and not relieved on getting forward position.
Pericarditis will have pleuritic chest pain.
Yes, sir.
Why should pericarditis have pleuritic chest pain? Pericarditis should have pericarditis chest pain, no?
Yes, pleuritic type of chest pain, sir. Pain increases on inspiration.
What is that pleuritic type of chest pain?
Pain increases on inspiration and coughing, sir.
Well,
And
that's not
worsened by
essential.
lying.
Okay, it can worsen with lying. I agree because the pericardium
Yes,
comes
sir.
into contact with each other. But the changes with posture.
Yes, sir.
Respiration is not a good sign, but changing with the posture is more common. Okay. Then, if it is pericarditis, how do you explain the dyspnea? How can acute pericarditis produce dyspnea? Come on, quickly. Anybody?
Pericarditis developing pericardial effusion, sir.
Yeah, massive effusion. That is
Massive
only.
effusion.
Yeah. Okay. And the last one is left-sided valvular heart disease worsened with acute MI. Which valvular heart disease are you thinking of?
Aortic valve disease, sir.
Okay.
Aortic stenosis, I'm thinking of aortic stenosis, sir. Patient, in case of aortic stenosis, patient will have angina, syncope, and dyspnea, sir.
Why should they have acute MI?
Yes. It
Acute MI is different from angina. No? Aortic stenosis will have angina. But why should they have acute MI?
80% of the aortic stenosis patient will have coexisting coronary artery disease.
80%. Oh, not at the age of 54 years. You're talking of senile aortic stenosis, not at this age. Okay. Theoretically, calcific aortic stenosis can have coronary embolism and present as acute MI. Otherwise, severe aortic stenosis produces anginal pain and LV dysfunction with LVF. Acute MI is not a feature of aortic stenosis or coexisting coronary artery disease. Okay. So your first diagnosis is acute coronary syndrome.
Yes, sir.
Acute coronary syndrome, why anybody else can answer, not Ramesh. Why should acute coronary syndrome develop left ventricular failure?
If the amount of myocardium jeopardized is very large, sir, leading on to LV systolic failure, leading on to ventricular failure.
So a large
one
myocardial
possibility.
infarction. Okay.
One possibility, sir, or can be because of any mechanical complications like acute MR or ventricular septal rupture, sir.
Okay, that is point number 2. What else? Okay,
The intermittent arrhythmia can cause left ventricular failure.
possible. Okay, that's fair enough. So those are the conditions we like to keep in mind. A patient who had acute coronary syndrome followed by acute left ventricular failure, the first thing we think of is extensive myocardial infarction. And second thing with LV dysfunction. And the second one we think of is some mechanical complication. Okay, go on. Next slide.
Coming to general examination, sir. Patient is conscious oriented, kept in semi-recommended posture, and connected to nasal oxygen through nasal prongs. Right cannula kept on our left hand, and peripheries are warm. Patient was dyspneic and tachypneic. He is not anemic, not cyanosed. Bilateral pitting pedal edema is present, not yttric, no thyroid enlargement. JVP was elevated 5 cm above the clavicle. Prominent A and prominent B waves are seen. Vitals. Pulse rate 102 per minute. Regular, normal volume, no radial, no radiofemoral delay. Palpable in all peripheral vessels, no vessel wall thickening.
What is the RA pressure in this case? Roughly.
Uh, 14 sir, above clavicle, sir, 5 cm. From sternal angle 4 cm, sir. From to right atrium 5, sir. 14 centimeters, sir.
14 centimeters.
Centimeters of water, or it comes around 10 mm. Sir. We have multiplied into 0.736, sir. Converted to mm of Hg, sir.
Okay. So say 11-12 millimeters of mercury. So would that be, is that normal, high?
High, sir.
High. Okay. Go on.
Blood pressure. Right upper limb 110/70, left upper limb 110/70, sir. Right lower limb 120/70, left lower limb 120/70, sir. Respiratory 22 per minute, regular thoracoabdominal. Saturation, at saturation 86% in room air, sir. 94% with oxygen support with 6 liters of minute, sir. And temperature is normal, 98.4, sir. BMI is 40 kg, sir. According class 3 obesity, sir. Morbid obesity, sir.
Okay. So why saturation is 86 and increasing to 94? What does it suggest to you?
Acute left heart failure, sir.
Why acute left heart failure? Room air 86%, oxygen 94%. What does
Improved
it?
with oxygenation.
Yeah. So what? So what does it mean? Tell me the mechanism of hypoxia and why oxygen is improving the saturation. We have discussed the mechanism of hypoxia so many times, no?
Yes, sir.
Why do you say this suggests left ventricular failure?
Supply demand mismatch.
I will
because
say I will say this is a cyanotic heart disease. Suppose I want to say. Or I will say he has got maybe lung disease. Anybody?
The patient with cyanotic congenital heart disease, the saturation will not improve, sir. In cases of any lung disease or any congestion in the lung, the saturation usually improves.
So then in cardiology of fellow, next time you see a cyanotic patient, don't give oxygen, okay? If cyanotic patient won't improve, then why do you give oxygen? Cyanotic spell also you won't give oxygen. Am I right?
No, sir.
Yeah, that's what you are telling. Anybody?
Sir, according to the history and presentation, patient was admitted with MI and probably pulmonary edema, sir, alveolar edema causing exudative due to the exudate in the alveoli, there is hypoxia, and with oxygen it is improving, sir, according to the history.
According to the history, you tell mechanism of hypoxia in this case. One is you said alveolar edema. Anything
Yes,
else?
sir.
Anything else? No, for example, I asked you, why can't it be lung disease? I say he has got pneumonia. That's why he is hypoxic. What is the difference between oxygen response in Sorry? Hello? Go ahead. No, the hypoxia we have not finished. See, in cyanotic congenital heart disease, when you give oxygen, don't say saturation doesn't increase. Saturation always increases. But it does not increase to normal levels. In the sense that the saturation may not become 100%, but more important, the PO2 will not rise above 200. That is what is the important thing in cyanotic heart disease. That is what is hyperoxia test about. The hyperoxia test doesn't say the saturation doesn't improve. It always improves because dissolved oxygen improves even in cyanotic heart disease. The dissolved oxygen improves in the pulmonary vein. So when it comes into the arterial blood, the hemoglobin saturation will increase. But it cannot increase 100%. It cannot increase PO2 to more than 200. That is the difference.
Okay, sir.
Whereas if you have a primarily problem with the lung, when you give more oxygen, you can overcome the oxygen uptake problem. And therefore, the saturation can increase from a low level to nearly 100%. The PO2 can also increase in the arterial blood. Right?
Yes, sir. Okay, sir.
So, in this case, there are two causes of hypoxia. One, because of interstitial edema, the lung becomes very, very stiff. So, there is an element of restrictive lung disease. It's an acute reversible restrictive lung disease. In addition, there is alveolar edema. Therefore, oxygen transfer from the air into the capillary blood does not happen. There are two causes. Okay. So, in one way, it is a type of lung disease only. Yes?
Yes, sir.
But in another way, it is also a type of AV shunting because an area of the lung, the basal area which is edematous, which is full of fluid, there the oxygen is not able to be transferred. But the pulmonary blood flow is continuing in that area. So there is a arteriovenous mismatch. Sorry, not arteriovenous. What is that? Oxygenation versus flow. Perfusion, oxygenation mismatch. Perfusion is continuing. Ventilation, perfusion. Perfusion is continuing, but ventilation in that segment is not happening. Yes? No.
Yes, sir.
Yes, sir.
So so this is behaving partly like a shunt, partly like a lung disease. Agreed?
Okay.
Yes, sir.
There is
Yes,
a perfusion ventilation mismatch in the edematous area. There also is an element of lung disease in the sense there is fluid. If you give more oxygen, that more oxygen can penetrate into the capillaries. Therefore, oxygen does improve the saturation, will improve the PO2 also, but it may not improve it to complete normal because the AV shunting part, the ventilation perfusion mismatch part, cannot be improved by oxygen. You agree?
Okay.
Yes, sir.
Okay.
Yes.
So this is a mixed problem. This is a lung problem as well as a AV shunting problem. So with this history, I agree with you. With this history, you must think that hypoxia is due to alveolar and interstitial pulmonary edema. Okay. Let's go to the next slide.
Systemic examination, sir. On inspection with an palpation, chest wall is bilaterally symmetrical, trachea in midline, no visible pulsations, no dilated vein, scars, sinuses, no chest wall deformities. Apical impulse felt in left fifth intercostal space in mid-clavicular line. A systolic thrill felt in left third, fourth, fifth intercostal spaces.
Okay. What the apical impulse? You are not described the apical impulse character, no? That's an important finding.
No specific characters.
Okay.
No specific characters.
One.
Percussion, upper bottom of the liver dullness is present in right fifth intercostal space in mid-clavicular line. Right heart border corresponds to substernum. Left heart border corresponds to apex. Auscultation, S1 is normal in intensity. S2 wide with a variable split. Left ventricular S3 here. No S4. No pericardial rub. No click here. A high pitch, harsh, long pansystolic murmur of grade 4 by 6 appeared in the left, third, fourth, fifth intercostal spaces with diaphragm of stethoscope appeared in expiration. No ejection systolic murmur in aortic area, no early diastolic murmur in aortic area, no pansystolic murmur, no mid-diastolic murmur in mitral area.
Okay.
Respiratory system, bilateral fine inspiratory crepitations here all over the lung face.
Okay.
On examination of the abdomen, it's soft, distended. Liver is palpable 2 cm below the right costal margin. CNS, no focal neurological deficits.
Okay. So, what are the possibilities? Anybody? Somebody come for answer. What are the possibilities?
Possibility of ventricular septal rupture, sir, because of large myocardial infarction.
Because of a
Large myocardial infarctions, acute MI.
okay. And any other possibility?
Ischemic MR also is a possibility, sir.
Between the two, which one would you like to put first?
VSR, sir.
VSR.
Yes. Why? Why?
Thing is, there is a thrill along with a murmur here in the left third, fourth intercostal space, sir, just lateral to the sternum.
Why
More in favor of.
MR cannot produce a thrill, and MR cannot come to the parasternal area.
Usually, acute MR in these kind of patients will not have a thrill, sir. It will be very faint. There is a thrill. First possibility is VSR, sir.
Okay. Yes. Why thrill is faint? Why the thrill is faint in acute MR?
It is posteriorly directed, sir, usually.
Always.
So,
Which MR is posteriorly directed and which MR is anteriorly directed? Come on guys, these are all daily questions. Don't take so much time. Which MR is directed posteriorly, which MR is directed anteriorly?
Mitral valve prolapse MR posteriorly and ischemic MR anteriorly, sir.
That's the MBBS answer. Not acceptable at DNB level.
If anterior mitral leaflet is involved, it is posterior, and posterior mitral leaflet anteriorly directed jet.
Okay. So in this case, which system is involved? Anterior or posterior? If it is MR. Suppose if it is MR.
Posterior, sir.
The
Posterior.
radiation part he hasn't mentioned, sir. So according to the radiation, we can differentiate between anterior directed or posterior directed.
So he did mention, no? He said the murmur is best heard in the parasternal region. He didn't mention?
Radiation.
What is radiation? Radiation. The murmur is
Radiation
arising in
to
mitral
the
area, but he is
frontal and
hearing it in
back.
the. Okay, not on back, but he is best. Okay, Ramesh, are you there? Did it radiate to the back axilla? But you are written in the parasternal region, left, third, fourth, fifth intercostal space.
Yes, sir. Murmur here on the left third fourth space alone only, sir. No murmur in mitral area, sir.
What about in the axilla and what about in the posterior scapular region?
No murmur is not here and on that spaces, sir.
Okay. So now your question is answered. Now you tell me which anterior mitral leaflet system or the posterior mitral leaflet system is involved if this is MR.
The posterior mitral leaflet system is involved.
Why?
Usually AML involvement, it will be directed posteriorly. The murmur will be radiating to the back, sir.
You have not been attentive in earlier classes, Amudan and Surya, both of you. I've told you, I discussed an acute MR with you, one of the case discussions earlier. I specifically told you mitral valve prolapse and ischemic MR behave in opposite directions. When it comes to mitral valve prolapse, posterior apparatus murmur goes anteriorly. Anterior apparatus murmur goes posteriorly. In case of ischemic MR, the posterior apparatus murmur goes posteriorly. And anterior mitral papillary involvement, the murmur will go anteriorly. Ischemic MR and mitral valve prolapse behave in opposite directions. Please go and read.
Okay.
Sir.
So if this is MR, it has to be involvement of the anterior mitral apparatus. Right. So what do you think the LV function in this case is? If you think it's a ruptured VST, okay. What do you think of the LV function in this case? Anybody in the audience, not Ramesh. How is the LV function? I'll give you three choices. Mildly impaired, mild impairment. Another one is very severely impairment. Another one is normal. Three categories I'm giving you. Come on, guy, don't take so much time.
Severely impaired, sir.
Who is answering?
Gautam, sir.
Yeah, Gautam, what did you say?
Severely impaired, sir.
Severely impaired.
Yes.
Okay, everybody agree with that? Yes or no, you have to say, no? Somebody.
Yes, sir.
Everybody agrees with Gautam.
I
What are
think
the signs of
it's mildly impaired, sir.
why?
Because he said apical impulse is not hypokinetic, sir. It is normally felt.
Do you diagnose LV dysfunction by palpation? Hypokinesia you diagnose by palpation, is it?
No, sir.
Yeah. That's what you are telling.
The pressure to cause VSR from left to right shunt, the LV at least should be mild LV dysfunction. So if it is severe, then
No, that's not the right answer. Rupture can occur irrespective of LV pressure because of the necrosis.
okay.
What are the signs of poor LV function on physical examination? That's all. Indirectly, I'm asking you that question. Indirectly, I'm asking you, how do you make out LV dysfunction on physical examination?
Starting from the pulse, sir. The pulse will be of low volume pulse.
Tell me two, three important signs. Don't see, examiner will get very he will get very irritable and he will be in a hurry. Don't waste time, we're talking of small things and come straight to the point. Okay, he will be in a state of shock. What else? A VSD with poor LV function patient will be in shock, no? Okay, what else? What will be the first sound like? What will be the first sound like?
Muffled, sir.
Muffled. Yeah, he is clearly saying first sound is normal.
Yes, sir.
What will be the murmur like if the LV is severely impaired?
It will not be high pitched, harsh, sir.
Will it produce a pansystolic murmur?
No, sir.
Will it produce a pansystolic thrill? Yes or no?
No, sir.
No, sir. No, sir.
So then, the very fact that he's telling that a hard, high pitched, prolonged pansystolic murmur with a thrill, the first sound is normal, patient is not in shock. He's in LV all right, but she's not in shock. Indicate that the LV function cannot be very bad.
Okay.
Okay. Okay, next slide. Go on, Ramesh. So, what was your impression?
Coronary artery disease, acute coronary syndrome, biventricular heart failure.
Acute coronary syndrome. Even now, it is acute coronary syndrome. Acute coronary syndrome involves angina, unstable angina, stable angina, everything. You think you're still acute coronary syndrome? Acute coronary
Yes,
syndrome will angina will produce rupture of septum.
No, sir.
You are diagnosing a mechanical complication. Does it occur in any condition other than ST elevation MI?
No, sir.
Then what is the problem? So why don't you say acute myocardial infarction or recent myocardial infarction?
Yes, sir.
Then
Acute ventricular septal rupture, sir. Acute papillary muscle dysfunction,
so
sinus rhythm.
you diagnose both.
Yes, sir.
Patient
First
can have
diagnosis is
both.
ventricular septal rupture also. First diagnosis is ventricular septal.
One of these.
Yes, sir. First
Okay.
is I'm thinking of ventricular septal rupture is first, sir.
Okay.
Sinus rhythm, systemic hypertension, type 2 diabetes, liver cauterization, class 4, sir.
Okay. And you have to add the term of LV function of not too severe degree, LV dysfunction. That is the clinical impression. Okay,
Yes,
go
sir.
on. Next.
For management, I want to do basic
Okay.
investigation, sir. Complete blood
Okay.
count, blood sugar, troponin, BNP,
Okay.
COVID-19 19 testing, sir. So I will show ECG first, sir.
Go on.
Shall I read, sir?
Yeah, please.
Systolic ECG with a normal standardization, sinus rhythm at heart rate of 100, normal axis, with Q with a S elevation noted in V1 to V5, and ST depressions noted in two inferior reads, suggestive of acute antival myocardial infarction, sir. Evolved antival myocardial infarction, Q with S elevation, sir.
With sinus tachycardia.
With sinus tachycardia, sir.
Anything else? Anything else you look for?
S elevation present AVR also, sir.
Yeah, what else? Any LA enlargement?
No, sir. No left atrial enlargement, sir.
You must say that, no? Because if you are diagnosing large VSD, acute MR and all, no? LA enlargement, you have to specifically say that. Okay, go on. Next slide.
Yes, sir. Chest X-ray, sir.
Okay, read it. Go on.
Chest X-ray AP view, normal exposure, normal penetration, cardiothoracic ratio 0.65, apparent cardiomegaly, sir. LV type of typical effects with right atrial enlargement, prominent aortic knuckles, sir, with curly B lines seen in in periphery, sir, and there will be pulmonary plethora and supplication of vessels are noted, sir. No mitral valve or aortic valve calcification, sir, which is suggestive of pulmonary venous hypertension with pulmonary edema, sir.
Pulmonary venous hypertension, pulmonary edema, I agree. But you also said something about plethora.
Yes, sir.
There's a
seen
difference. So it's a combination of pulmonary venous hypertension and plethora, no? You see, can you see the multiple end-on vessels seen in both sides?
Yes.
There's a very good X-ray for acute plethora, no? Okay. All of you can see the end-on vessels. There's rounded shadows in both the hilum.
Yes, sir. Yes, sir. Yes,
And
sir.
you also see the lot of rounded. Wait. Lot of rounded shadows in the hilum. In addition, there is the curly B line, and the upper lobe veins are very prominent.
Prominent.
Yes.
So it's a combination of pulmonary edema and pulmonary plethora. Okay, go on.
Trans echo, what do you
Okay.
Sir, 1 minute, sir.
Well, what about the transthoracic?
It's a bedside.
Find it?
Only report is only available, sir.
Okay. So
First, I will show the TV video, sir. After that, I will show the report, sir.
okay, go on.
Yes.
Okay, one of you should interpret the transesophageal echo. Once a minute, let us decide who is going to interpret. Who is commenting on the transesophageal echo?
Gautam, yes, sir.
Gautam, okay.
Sir, it is used to be a transgastric view. Transgastric shot. Just a minute. The transgastric short axis view, sir. Showing
wait. Can you freeze it 1 moment? Okay, how do you get transgastric view?
transgastric views, we have to insert the probe into the esophagus of more than 40 centimeters.
Huh.
And after 40 centimeters,
and then?
Sir?
After that, what do you do? No, wait. you push it 40 centimeters, you'll get transgastric view.
No, sir. We have to anti-flex probes.
Okay, so anti-flex it. You have to flex it so that the transducer faces leftward and upward. Okay, okay, right. Go on. What does it show?
This short axis view showing LV.
It should resemble a LV in short axis.
Short
But
axis.
actually, it is it's become oval. It's not fully short axis anyway.
Fully short.
Okay, it's gone again. Can you go back again? Freeze it when you get it. Freeze it. Okay, what do you want to tell us in this?
So there is echo deficit in the apical region, sir. LV contraction.
In the short axis, you don't get apical region and all, right? Short axis, how can you get apical region?
There's echo deficit in
the
Okay, anyway, this here the deficit is not very clear.
Yeah.
Go on, next. Okay, let's go to the apical view. Go on. Okay, this is also a transgastric view. What do you see?
Transgastric view, there is a turbulence of flow between the LV and the RVs.
Okay.
There is a turbulent flow between the echo deficit from the LV to RV.
Okay. So there is an interruption. You can see a gap there, and the corresponding area you also see the Doppler flow from LV to RV. Okay. Next. Somebody's mic is making noise. Go on. That's all?
No, sir. Another video is available, sir.
Okay. Apical view?
No, it's a four-chamber
view. Okay, not the four-chamber view.
Four-chamber view. This appears to be a mid-esophagus four-chamber view, sir. And it's showing the LV and RV, which is not properly, LV and LA not properly seen, RV and RA. And there is a color flow between the color flow Doppler, which is not clearly seen.
Okay. Let it run. Keep running.
And there is a mild MR and VLTR.
Let it keep running. Next one.
There's two videos available, sir.
Only two videos.
Yes, sir. Post-operative videos available, sir.
No, not now.
Shall I?
Okay, no, not now. Okay, so what is the diagnosis? Gautam?
Sir, there's a ventricular septal rupture.
Okay.
And there is a ventricular septal rupture from the LV to RV. And there is a color flow between the LV to RV.
Okay. Now, are you satisfied with these images, or you want some more information?
No, sir, I want some more images actually. I cannot quantify the MR.
MR, you said mild, no?
Mild excess.
What other information do you want? Okay, come on, quickly. Okay, anybody else?
Sir, I would like to know the size of the ventricular septal rupture, sir, extent of it.
Echo is the best way of measuring the size of the defect, no? You have to know the size. What else? What else? Are you clear about the location?
Yes, sir. No, sir. The location is
What?
not
Yes,
clear,
sir.
sir.
Yes, sir. No, sir.
No, no, sir.
No, sir.
I'm not
So you have to
sure
know the
about the
exact
location.
location, whether it's at the distal part of the septum, proximal part of the septum, anterior part of the septum, posterior part of the septum, whether it has adequate borders, whether, or it is formed, it is adjacent to one of the valves, adjacent to one of the free walls, whether the adjacent free wall is thinned out, whether the adjacent free wall is aneurysmal. There's so many things you have to tell. No, don't go. It's not enough if you read two views and say I have done.
Okay,
This
sir.
information is not enough. Okay, do you have any information transthoracic echo report?
Yes, sir.
Can't read it. Can you make it bigger? Or you read it out?
Yes, I will read, sir.
Slideshow.
Sure.
Okay.
Sir.
Regional wall motion abnormality present.
Abnormalities.
Go on.
Akinetic mid-anterior interventricular septum and mid-anterior wall. Thinned out. Akinetic apical interventricular septum and LV apex. No LV clot. Dilated left ventricle with severe LV dysfunction. EF 25%. Mild mitral degradation. Acquired apical muscular ventricular septal defect. 12 mm. Left to right turn with velocity of 3 meter per second. Dilated right atrium, right ventricle and pulmonary artery. RV dysfunction. Severe tricuspid degradation. TR velocity 3 meters per second. Dilated IVC, right side pleural effusion, intra-atrial septum intact, normal mitral, aortic, tricuspid and pulmonary valves.
So in this case, it's an anterior myocardial infarction and he's got an apical muscular VSD. Is that the common location of VSD for anterior wall MI?
Yes, sir.
Yes. So where does, in posterior wall MI, inferior wall MI, where does the VSD occur?
Basal septum, sir.
Basal septum, okay. So, okay, go on. Now, so you got the report. What else, any other investigation you want to tell us?
Yes, sir. So I want to the coronary angiogram, sir.
Yeah. So tell us. Yeah, read it out, no problem.
Ileocranial view, which shows
No, don't go view by view. Just tell us the finding.
LAD type 3 LAD has subtotal LAD occlusion with TME1 flow in mid and distal segments. LCX non-dominant LCX have mild distal disease. Yearly arising OM has 80 to 90% proximal segment stenosis and OM2 has mild distal disease. RCA dominant RCA has 70 to 80% stenosis after RV branch. Right PD has mild proximal disease. Impression coronary disease, triple vessel disease.
Okay, we have got 3 vessel disease, no?
Yes, sir.
Which of these disease caused this ventricular septal rupture, you feel?
Left LAD, sir. Left anterior LAD, sir.
Why?
Location, sir. And anterior one-third of anterior two-third of interventricular septum is supplied by anterior interventricular branch of septal LAD, sir.
Okay.
Septal branch of LAD, sir.
Right.
So the location is apical and anterior, sir. So I'm thinking of LAD is the main cause, sir.
Good. Okay. So now what do you want to do? What was the size of the VSD? That we never did you tell us?
Yes, sir. It was mentioned 12 mm, sir.
12 mm. Okay.
Yes, sir.
Good. Okay. Right. Now what would be your plan? Anybody else in the audience? No, you can tell us later. Let them say. What would be your plan, Surya?
Sir, this patient has got critical triple vessel disease with ventricular septal rupture and LV dysfunction, and she has already crossed 1 week, sir. and that will be ideal time for closing the ventricular septal rupture. And since there is a triple vessel disease, I would like to advise her for CABG with grafts to LAD, OM, and RCA, along with patch closure of ventricular septal rupture as well, sir.
Okay. Now, there's a 1 week is not really ideal. No? People say after 2 weeks only
2 weeks,
collagen sets in. So
Yes, sir.
1 week is a little early. 2 weeks is I would have agreed for that's a good case for the thing. At 1 week
Okay,
she's
sir.
still on the borderline. Collagen would still not be strong. There'll be myocardial edema and the edges would be still friable. So okay, that is one option. So high risk surgery with BSD closure and bypass. Now she is in class 4 and surgeon says no, it's high risk. Why don't we wait for 1 more week? Then what would you do? Surgeon says no, it's a high risk still. Can you stabilize her and then we'll take her up next week?
Mechanical circulatory support
What is
system.
with what?
It's something like Impella or a heart map.
IABP, sir, initially.
Everything.
Yeah, you talk of things which are available here first, no? Talk of
Yes, sir.
most
IABP is
without talking IOBP, if you talk of Impella, no? I don't think the examiner will be very impressed.
sorry, sir.
Okay.
First IABP, then.
So, how does IABP help in this case?
Oh.
How does IABP help?
Increase the myocardial oxygen supply and decrease the myocardial oxygen demand, sir. And there will be improvement of cardiac output because of increasing coronary perfusion pressure.
Increasing coronary perfusion, you are improving myocardial function. We are worried about the VSD rupture, no? Mechanical complication, VSD, not the, are you trying to treat the ischemia or are you trying to treat the VSD now? What you're telling is improve diastolic perfusion in the coronary, helps to improve coronary perfusion. How does that help the VSD? They're all very, very simple questions. If you have read IABP properly, then you'll answer.
Increasing the due to diastolic augmentation, there will be increased coronary perfusion, sir. Thereby, it will help in healing of the edges of the VSR also, sir. In this case, especially, and thereby
Healing. What do you mean healing?
Healing, sir.
Healing.
Heals.
Okay.
Healing, enhancing the healing of the.
Okay. Healing has to take place over 2-3 weeks. No, patient has to be kept alive till then. No. If the hemodynamics will kill her, what good is healing? I'm giving you a hint here. How does IABP help hemodynamic here? Don't talk of healing by hemodynamic by IABP.
It decreases systemic vascular resistance, sir, and decreases the shunt fraction.
No, it doesn't decrease systemic vascular resistance, but what it does is it increases diastolic aortic pressure, thereby it reduces systolic pressure. Don't you know in a counterpulsation, when there is a counterpulsed arterial tracing, the diastolic pressure becomes higher than the systolic pressure. Who discussed the IABP last week? Amazon, you discussed?
EECP, sir.
Okay, EECP there. That's also counterpulsation, yeah.
Yes, sir.
So the diastolic pressure becomes higher than systolic pressure.
Yes, sir.
And the systolic pressure dips, isn't it, below normal?
Yes, sir. Yes, sir.
Then why don't you say that? So you are reducing the LV pressure while increasing aortic perfusion pressure in diastole.
Okay.
Is that helpful for VST?
Yes, sir.
You say that reducing systolic pressure helps LV function, helps reduce the shunt, and therefore the hemodynamics improve. The shunt reduces, PA pressure improves, pulmonary congestion improves. That way. Healing comes much later. Hemodynamics have to improve first.
Okay.
Okay. So you have done IABP. What else can you do?
Is an frank pulmonary edema and class 4 dyspnea. She requires intubation and ventilation, sir, for
Okay, you okay. How does it help the LV function?
Innama.
Yes, yes. When you remove the work of breathing and you keep the patient sedated, the LV function, the LV work decreases. Okay, so that's a good idea. So you have to ventilate and take away the work of breathing, and it also improves pulmonary edema because it pushes the water back into the lung. Okay, so one is ventilation. Second is IABP. What else? Oh my God! Every day these things are being done, and you are not talking.
ECMO, sir.
Usha, 1 second. Just hold on.
மியூட் பண்ணிக்கிறேன் நினைக்கிறேன்.
Hello? Yeah. Hello?
Yes, sir.
Yes, sir.
Ah.
Yes, sir.
So what was I saying? It improves the LV diastolic, improves aortic diastolic pressure, reduces LV systolic pressure. Then what else can you do to do the same thing? How else can you reduce the systemic resistance? Don't you talk of nitroprusside, nitroglycerin?
Yes, sir.
What's wrong with you? Why are you not telling that? Her pressure is more than 110. So why can't you give nitroglycerin or nitroprusside?
Yes, sir.
Okay, what else can you give?
And diuretics can be given. So
Diuretics,
or
sir.
diuretics.
No, these are all you should give 1, 2, 3, 4. You should tell, no? You're taking so long to tell all this. Okay, tell us, Ramesh, what did you do? Ramesh?
No, sir, poor network, sir.
So 1 minute, sir.
Okay. So you
The
plan to
surgical
do
VSR
surgical.
approach
Okay, go on.
with CABG, graph LAD and PDA, sir. The procedure notes,
No,
sir.
no, wait. When did you want to do it? When did you do it? How many days after the?
Usually after that's sir, VSR surgical VSR done on second day of admission, sir.
No, not admission. I'm not interested. Tell me from the infarction. No, that is more important for us.
Sir, it was
Usually
almost done
after
after
7
2
days,
weeks of
sir.
myocardial infarction.
Huh?
Should be done 2 to 3 weeks after infarction, sir.
No. In this patient, how many days after MI was it done?
Sorry. 9th day, sir. Second, end of first week, sir. Actually 9th day, sir. Patient presented.
Okay, 9th day. So it was into the second week. Okay, that's what I wanted to know. Right. So okay. So surgical VSR closure with grafts to LAD and PA. Anything else you did before that?
Hemodynamic stabilization was done with IABP, sir.
What else? Only IABP, and you didn't have nitroglycerin, no nitroprusside, no diuretics, ventilation.
On second day, patient went to hypotension, sir. BP was 90/70, sir. So nitroglycerin was not started, sir.
Okay.
Patient was supported with inotrope, sir.
Okay. What about ventilation?
Intubation was done, sir, on second day, sir. Saturation
That's what
was
I want. You tell us
84%.
everything, no? Okay. Okay. Right. Go on. Next.
The procedure notes, sir.
Okay. That's fine. Patch the VSD. No. Okay. Next.
Post-operative follow-up, sir. Patient was shifted to ICC after VSR closure and CABG with IABP support, sir. And IABP was removed on third post-operative day. Extubation was done, sir. On fifth post-operative day, inotropes was gradually tapered. Her BP was maintained at 126/80 without inotropes, sir. It was gradually improved. Her saturation is maintained around 96% with 2 liters of with 3 liters of oxygen and shifted to room, sir.
How much was the post-operative LV function?
LV function is improved, sir. For 40%, sir.
Okay.
Previously, severe LV dysfunction, sir. 25%, sir. Last echo shows improvement in LV function, sir.
Okay. Right. Okay, that's a good case.
Shall I show?
Show. The network is not good. Okay, it's all right. Forget it. Now, can anybody tell me what type of VSD rupture is this? What are the types of VSD septal ruptures, and what type is this patient?
Type 3, sir. Type 3, sir.
What is type 3?
Oh, sir, it must be type 1. Sir.
Oh, suddenly it changed to type 1.
No, sir.
You have to tell me, okay, now you want to change it to type 2 now?
Sir, type 1 only. Type 1 only, sir.
So what is type 1?
Rupture with a slit-like tear.
Hey, somebody's mic is echoing.
Slit-like tear usually associated with acute infarct, sir, within 24 hours of onset.
Okay. So what is the mechanism of type 1 septal rupture? Anybody?
Because of infarction, sir.
Hey, all of them are because of infarction, man. Don't give me that answer. All of them are because is anyone without infarction?
Necrosis and infarction.
Infarction means necrosis. Infarction means necrosis. Yes, Nishad, you said type 1. No, what? Type 1 infarct, type 1 septal rupture occurs within the first 24-48 hours. It's usually due to a myocardial hematoma. There's a ventricular myocardial necrosis, a big hematoma forms with ruptures. Type 2 occurs. When does type 2 occur?
Type 2, they usually have to have a subacute presentation, sir.
When does it occur?
3 days post infarction.
Okay, 3 to 7 days. And what is the mechanism of subacute rupture?
Because of the erosion of the infarcted myocardium.
Okay, why does erosion occur?
Because of slowly progress tear, sir.
Because the muscle, necrotic muscle, is weak and the LV pressure keeps on eroding the necrotic myocardium. Okay?
Yes, sir.
Erosion of the weakened myocardium. Type 2. And what is the type 3? Type 2 also, by that time, the new polymorph and macrophages would also come in and they would start eating away the necrotic muscle. So there is weakening of the myocardium and erosion. Okay, what is type 3? When does it happen? How do you identify?
Aneurysmal formation, sir.
Yes, there is an aneurysm formation. There is a dyskinetic area and there is a thinned out infarcted area. In the thinned out area, the thinnest portion ruptures. That probably is due to the phagocytic clearance and all that, and the weakest portion gives way. So type 1 is hematoma rupture, type 2 is erosion of the necrotic weak myocardium, type 3 is erosion of a aneurysmal thinned septum. Okay? And there is also another term used, simple and complicated.
Complex. It's a simple and complex.
Simple and complex. What is that?
Simple usually located anteriorly.
What is the difference between simple and complex? First tell me that.
Sir, in simple,
If there is a track or if there is no traction.
Yeah, there is a direct hole. There is a simple hole between LV and RV. With a direct shunt, it is called simple. If you have an indirect track going through the myocardium, it is complex. Generally, the type 1 is always simple because it ruptures in the acute phase of the hematoma. That's usually simple. Type 2 can be simple or complicated. Quite often complex. Type 3 is always... Sorry?
I have a doubt, sir. Sir, will hematoma happen on the first day itself, sir?
Yes.
I thought first type was the intimal tear with erosion, and subacute was hematoma, sir.
Hemorrhage occurs, no? Whenever the bleeding infarct occurs, hemorrhage occurs, no?
Okay, sir. Okay, sir.
Then type 3 is thinning of the septum.
Yes, sir. Aneurysmal formation.
Usually it is a straight shunt. It's not a serpiginous shunt.
Okay, sir.
So usually it's more simple. The type 2 is the one which is often. So this one is likely to be what? Is this a favorable defect or an unfavorable defect? Now thinking back. If you were to prognosticate this patient, was it a good prognosis patient or a bad prognosis patient?
The anteriorly located or a good prognosis than inferiorly located VSR.
No, don't. Okay, that is one point in her favor. What else? What are the other points in her favor?
Defect size, sir, is a 12 mm, sir.
Yeah. Is it?
It's not
Is it?
multiple, it is not having serpiginous cores.
It is a simple defect. It is not very big. Very big means more than 15 mm. So it is not a big defect. It is a simple defect. Therefore, it is a good prognosis. This patient is in good hemodynamic shape. She has survived 1 week without any intervention. That itself is a good sign. Yes or no?
Yes, sir.
Yes, sir.
Without going into shock, she has survived 1 week and she has been able to travel from Nellore to Chennai. So that itself is a good sign. So she has all the good prognostic sign. One, she doesn't have major risk factors in the form of kidney disease, very elderly age group, or poor general condition. Of course, she is a diabetic. Okay, but surprisingly, actually, diabetes is not a risk factor for VSR mortality. Kidney disease is a risk factor, but not diabetes. Okay. Secondly, she has survived for 1 week without shock. So that's a good sign. Thirdly, the defect is not very big. Fourthly, it was an acute defect occurring within the first 48, which is a simple defect. All these are good signs. If it's associated with shock, it is a serpiginous core. If the patient is in bad shape and shock, and if it is accompanied by multiple morbidities, then it is a bad outcome. Okay?
Yes, sir.
Suppose he was in severe shock and she came at the 3rd day, 5th day. He was in severe shock with no urine, with very little urine output, and IABP barely maintaining 90-100 pressures. What would be your approach?
If patient is hemodynamically unstable, we will proceed for emergency surgery only, sir. That is the option, sir.
Any other option?
VA ECMO can be put, sir.
Okay, ECMO can be attempted because that's a much more effective way of
Than IABP.
stabilizing than IABP. I agree. One more. What else can be done? But still, that's only a temporary phase, no? What
Yes,
about
sir.
device
Bridging.
closure? Why don't you consider device closure? It's an anterior defect, apical accessible. Secondly, it is only 12 mm. It's not very big. So, if surgery is a poor candidate, a less traumatic procedure would be a device closure.
Okay, sir.
Because generally anti-wall VSDs have good margin and accessible, not like a posterior basal defect. So I think device closure should be the one if surgery cannot be done.
Yes, sir.
If you are in a place where device closure also cannot be done, the patient is in bad shape due to large shunt, what will you do? You have a cath lab, but you do not have device.
Go for the rescue PCI to the culprit artery.
And forget the VSD. How will PCI help if the VSD is still there? That's the wrong answer. The problem is coronary or the problem is VSD now?
VSD, sir.
ESD, sir.
Why are you taking rescue PCI? In fact, you can do VSD closure and not do the PCI because infarction has already happened. There is no hurry to do PCI at all. In fact, when we do VSD device closure, we don't bother about the coronary occlusion. We just do the VSD come out, let the patient stabilize, and then deal with the coronary disease.
Balloon occlusion, sir?
Yes, balloon occlusion is a temporary balloon occlusion is one of the answers. You can put a balloon You can put in fact, the defect is small, even a Swangan balloon or a Berman angio balloon would be enough to reduce the shunt. Otherwise, you can put in a sizing balloon and just leave it there. It'll help stabilize the patient. Okay?
Yes, sir.
Right. So, any questions on that?
But you told we have to wait for a week at least for an closure of the VSD to stabilize the patient. How come third or fourth day we close the VSD?
If the patient is in shock and no urine output, not improving IABP, you do not have facilities for ECMO and this thing, then what do you do?
Yes, sir.
Patient will not survive for 1 week, man, then.
Okay, sir.
Patient can survive only, you will wait, no?
Yes, sir. Yes, sir.
Okay, any other question? No questions? Okay, then I'm winding up. Thank you.
Thank you,
Thank
sir.
you,
Good
sir.
case, a good case, Ramesh.
Thank you,
Huh?
sir.
Thank you, sir.
Thank you, sir.
Thank you, sir.
Sir,